It's a pleasure for me to be here with you after a long day for all of you, I think, and I hope that you're enjoying ESMO. And I'm really happy to be here with my colleague, Professor Zhang. And our role is to coordinate a discussion with all of you. And I'm very pleased to have with me my esteemed colleague to speak about VEGF inhibition and the role of VEGF inhibitors in the landscape with a focus on fruquintinib use in the USA. And I thank my colleague Kathy Hang for being here. And to have, I hope, an interactive discussion on which are our different experience with the drug. I'm Sara Lunardi. I'm an Italian oncologist. I'm working in Padova, that is a city near Venice, northeastern part of Italy. And I'm leading the oncology department at a cancer center called the Veneto Institute of Oncology. So I think that we can really very quickly jump and go deep in all the topic that we have to discuss today. So please, Professor Zhang, if you want to introduce the work for tonight.
Thank you very much, Professor Larry. It's my pleasure to join Professor Larry in the year to give everybody here for this important forum dedicated to successful testing our tumor. Here in ESMO 2025, I believe it's our chance for us to meet this new city. As we begin this session, we reflect on the growing role of Chinese clinical experience and the research in the global oncology community. Tonight, we will exchange and explore both international and Chinese approach to the use of VEGF inhibitor in the metastatic colorectal cancer. And we will discuss how we can integrate this strategy into a continuum of care that will benefit our patients everywhere. I will express my deep appreciation to ESMO, to our international faculty, and to all of you in the audience for your participation. Everybody here presents and understood the value of cross-culture dialogue in medicine. And let's make the most of this evening, share knowledge, challenge conversion, and build bridge for future collaboration. And I'm glad to see Cassie again, and we meet several times in China and even in ASCO. But I'm sorry to hear she is not feel very well tonight.
Sorry.
So thank you everybody here. And next I will invite Cassie to give us the first speech. Cassie is come from the United States. Now he's a professor of Freiburg and Cancer Center. And he also is a member of ASCO, ECOG, and a lot of academic titles on her. So, please.
Sorry, we're trying to figure out if you want me to talk here or do you want me up there?
Please, just sit there, because it's a small group.
As you prefer, Kathy. If you prefer to stay put, that's completely fine.
Do whatever works. Sure.
Thank you.
So, oh my gosh, I apologize. Because I think she's recording. So I was asked, I'm Kathy Ng from Vanderbilt Ingram Cancer Center in Nashville, Tennessee in the United States. And I have had the pleasure of speaking at many symposiums with our colleagues from China. It's my absolute pleasure. And unfortunately this year I cannot go back to China. It's once again, I'm very honored to participate. So I was asked to discuss the benefit of anti-VEGF therapy based upon some of the ongoing approaches to treatment in metastatic colorectal carcinoma. Does this thing advance?
Yes. This button.
Okay, thank you. Sorry. So I think it's just really important to acknowledge that colorectal cancer remains a serious global burden. Just to kind of provide the framework for today's discussion and why we're thinking about treatment options. It's estimated that in 2020, more than 1.9 million individuals will be diagnosed with colorectal cancer, and by 2040, that'll be up to 3.2 million, unfortunately still resulting in 1.6 million individuals in the death of these patients. And then our 5-year survival for our surgically unresectable patient population still remains rather low. This quotes 14%. There's other data to suggest it's 16%. I like to periodically break it down by different countries, and then in Asia specifically, it's estimated, sorry, I clearly was tired. It's from 2022 to 2045, not 2025. That's a typo. So in Asia, it's estimated by 2045, there will be an increase of over 77% in the diagnosis of colorectal cancer. So we still need to work on prevention, and we still need to think about different treatment options. This is basically the current therapeutic landscape, which looks quite impressive since 2020, but in fact, obviously, some of these drugs have the same mechanism of action. It's just with different companies. But still, we are making some extensive breakthroughs, including combined chemotherapy with FOLFOXIRI, which is a new standard of care. And then more recently, we've had breakwater, which we'll have to fix that as well. That should be FOLFOX plus encorafenib plus cetuximab, with a median survival of 30.3 months for BRAF mutant patients. And then for our MSI high patient population, pembrolizumab alone has made a dramatic difference for our patients that are MSI high. And then more recently, we don't have the OS data yet, but we have the PFS data on CheckMate 8HW, which is looking at the combination of nivolumab plus ipilimumab. So I think many of us have seen this data regarding the Sunlight trial, which was specifically in the third-line setting of involving TAS-102 plus bevacizumab. And I think that this is a nice way to break it down, because there were a small percentage of patients, a little over 20%, that actually were bevacizumab naive. And in the United States, bevacizumab is a standard of care for frontline and second line and third line moving forward. But we understand that across the world, bevacizumab is not always provided in the first-line setting. So if you break it down by subgroups, the primary endpoint for this trial was overall survival, which they were able to fulfill, and it is now considered a standard of care. In Europe, this is the third-line standard of care. In the United States, it's one of 3 different options for third-line. But when you're talking about patients that had received prior bevacizumab, the OS was 9 months versus 7.13. And then for those that are bevacizumab naive, the survival is higher at 15.14 months versus 8.05 months. These are the NCCN guidelines, which I don't really know if other countries necessarily use. They're constantly being updated based upon an NCCN guideline panel. I do not sit on the panel, so I do not have any conflict. But they basically take the most recent evidence-based medicine and try to apply it to current guidelines, so it allows insurance approval because of the way the healthcare system is in the United States, which allows patients quicker access to treatment. So as mentioned earlier, obviously we have limited treatment options for our patients with surgically unresectable disease. And talking about FRESCO-2, I think we're very familiar since it has been approved already for quite a while in China, but once again, it's an oral TKI specifically for VEGF receptors 1, 2, and 3. And basically, the trials that have been completed thus far, we obviously know FRESCO-2, which resulted in the fairly significant approval across many countries now, looking at fruquintinib versus placebo in a 2-to-1 randomization with a primary endpoint of overall survival. And as we all know, the original trial allowed prior TAS-102 as well as prior regorafenib. The median line of prior therapies was 4, and they were able to fulfill our primary endpoint of overall survival. These were the patient demographics, which I think everyone has seen before. This is not new data. And these were the final results for overall survival of 7.4 months versus 4.8 months. And then for progression-free survival, it was 3.7 months versus 1.8 months. And the hazard ratio for overall survival was 0.66, so 34% increased likelihood of survival if you utilize fruquintinib versus placebo. Obviously, nowadays, we would try to avoid trials that utilize a placebo arm, but at the time that this trial was designed, we did not have any other treatment options, given that this trial did allow prior TAS-102 as well as regorafenib. Keep in mind, the TAS-102 did not necessarily include bevacizumab for obviously all of our sites. Quality of life has been evaluated extensively. This is just one of the posters that was presented by Alberto Sobrero, but we've had multiple various analyses looking at quality of life, which really has been very tolerable. Once again, primary toxicities have been hypertension, asthenia, hand-foot skin reaction as well. So the current indication, the global indication, as mentioned earlier in China, it is approved in the 3rd line or later setting. For our European colleagues, it is currently approved only in the 3rd line setting specifically. And so FRESCO is, I'm sorry, let me take that back. In Europe, TAS-102 plus bevacizumab is approved in the 3rd line setting, and fruquintinib is required to be provided after TAS-102 for our European colleagues. And then the United States, it was a pooled analysis of FRESCO and FRESCO-2 that resulted in the approval of fruquintinib in the 3rd line setting plus. This is just a breakdown basically of FRESCO-2 versus correct and recourse. Once again, I don't think many of us utilize regorafenib as much as we had in the past. And so I think it just demonstrates that there is benefit for this agent as an oral agent that has benefit of therapy on its own accord. Once again, this is a quality of life management. There's also, they did a little bit of a breakdown regarding adverse event management costs when you compare it across trials. However, we try not to do cross-trial comparisons, but this is just an analysis roughly of the cost. I know obviously cost varies per country. So here's currently it gives you an idea of the availability of fruquintinib. It's in 30 plus markets, and actually I just gave a talk to some Egyptian colleagues yesterday, and it is going to get approved there shortly in the 3rd line setting. That's my understanding. So how do you determine which is the best option if you have all of these options available to you in the 3rd line setting? I think obviously it depends upon the toxicities associated with treatment. There are some patients that may benefit very well from TAS-102 plus bevacizumab, but may not want to necessarily come in every 2 weeks for their IV infusion. And then there are those patients that have underlying myelosuppression, low white blood cell count, platelet count, etc. So in short, basically, FRESCO-2 demonstrates that there's improved survival versus placebo in our previously treated metastatic patients. The safety profile is manageable based upon several quality of life studies that have been conducted, and it currently is approved as 3rd line and beyond in 30 plus countries. So what are the future directions? This is a trial that just opened. That's my understanding, at least online. It looks like it just opened in September. Somebody correct me if that is incorrect, but that's what I found on Google. So this is the Fruition study, which is looking at fruquintinib plus TAS-102 in the refractory setting. This is of 120 patients with a primary endpoint of progression-free survival. Oh, and I should also mention, sorry. Does it go back? How do I make it go back? There it goes. Okay. We did present our data here. It was a poster of a smaller number of patients. There's only, I think, less than 50 patients with myself and Dr. Desari and other collaborators, which was conducted in the United States, looking at fruquintinib and atezolizumab as an option as well. And that was a poster today at today's ESMO. There's a lot of interest in the in zanzalintinib, which you'll hear a lot about tomorrow. And this is the Stellar 303 trial, which is in combination with atezolizumab versus regorafenib. And so we look forward to those results. And that'll be tomorrow morning. RAMPTAS is a study looking at the combination of TAS-102 plus ramucirumab. Ramucirumab, as you know, is approved in the second-line setting for metastatic colorectal carcinoma. I don't believe that there's much uptake in regards to its use in a metastatic colorectal carcinoma. This is a 1-to-1 randomization with the primary endpoint being overall survival. And in this analysis, TAS-102 plus ramucirumab for some reason did not demonstrate a benefit in overall survival, 7.46 months versus 7.0 months. Progression-free survival was also very similar, 2.37 versus 2.07. So this is basically also looking at the combination of anti-VEGF therapy with IO therapy. This is looking at sintilimab, which has been reported in the past, and here they did note some response. The response rate was 23% with a PFS of 6.9 months and an OS of 14.9 months. In this setting. And once again, as I mentioned, in the States, we looked at the combination with tislelizumab. And my understanding is in Germany, they're going to have a larger trial focused on tislelizumab in combination with fruquintinib, specifically in patients without liver mets. This is the, actually, I believe this is the trial, I'm sorry, that is looking at this specifically without liver mets. And so the primary endpoint here will be progression-free survival versus TAS-102 plus bevacizumab. And the primary endpoint will also include clearance of circulating tumor DNA. Oh, this is the poster we had today looking at pooled analysis of safety. Once again, it's just more to be informative about the potential toxicities of fruquintinib. And this is a pooled analysis of FRESCO-2, as well as a phase 2 study that was conducted of fruquintinib versus placebo in China. And I believe this is is this?
Yes. We presented today a poster on this kind of radiomic approach to confirm, to have a measure of the activity in inhibiting the effect of VEGF hyperactivation we have in cancer. And this tool, the artificial intelligence tool, is able to use normal CT scan to evidence the neoangiogenesis in cancer, and then the reduction of vessel, both as number and also as tortuosity. And the response in terms of vascularity is a biomarker for a better prognosis. This is the main message of the poster we presented. And we already presented on liver mets, and here we are presenting lung mets.
So it's very, very interesting. And I'm sure we're going to hear more about that because, as we all know, there's no biomarker that's been identified for anti-VEGF therapy. And this is just some information regarding expanded access program. I think actually Takeda with HUTCHMED has provided a very nice expanded access program for patients so that they are able to have appropriate treatment for their metastatic disease. So in summary, there's obviously multiple unmet needs in metastatic colorectal carcinoma in the surgically unresectable setting. We need to continue to find additional treatment options. And for those patients that you may want to place at risk for myelosuppression, or those that don't necessarily want to go in to receive their anti-VEGF therapy in combination with TAS-102, an oral TKI may be a great option. In this case, fruquintinib is an oral agent that is able to have benefit of therapy on its own accord, and combination trials continue to still be underway for further evaluation. So thank you so much. Sorry, my voice is not the best. So
Thank you, Kathy.
It's great. I think Kathy gave us a very good lecture. I think it's not from the option from the United States, but I think it's a global vision to see the anti-VEGF use and focused on the Chinese products of fruquintinib. And I'm glad to see that a lot of international professors has interested on that and do some researches and will get some clinical trial results in the future, and it will be improve our practice on the metastatic colorectal cancer patients. Okay, now I would like to invite the Professor Ji Xiaoping join us as a panel discussing. Professor Ji comes from the Shanghai. He worked at the Shanghai Ruijin Hospital, and he is very experienced on the patient's care about the metastasis and the early stage of colorectal cancer patients. And I think you can give some comments on the Kathy's lecture, or you can exchange your opinion about that.
Thank you very much for
maybe on.
maybe on.
I think I just hit the switch.
Yes. Thank you, Professor Zhang. It's my honor to take part in the ESMO 2025. Professor Casey introduced her experience for anti-VEGF in metastasis colorectal cancer, and it's very interesting. I'm a surgeon in colorectal cancer, so I think we need a safety post operation, the safety for post operation in colorectal cancer. So I think the treatment of patient with RAS mutated metastasis colorectal cancer and those with microsatellite stable tumors are currently the key challenge and focus areas. Improving the conventional resection rate for RAS mutated patient is very important. For initially unresectable RAS mutated MCRC patients, especially those with liver metastasis, enabling surgical resection opportunities through effective conversion therapy is crucial for improving prognosis. Studies such as the Beacon trial published in the JCO have demonstrated that the anti-angiogenic agent bevacizumab to standard chemotherapy significantly increase the conversion resection rate of liver metastasis from 5% to 22% compared to chemotherapy only. Therefore, actively exploring more effective conversion therapy strategies such as chemotherapy combined with targeted agents is an important current clinical research direction for RAS mutant MCIC patients. But the bevacizumab need to the complication after operation. So in my experience, we would use fruquintinib plus modify FOLFOX or modify KPOX to in the patient with liver metastasis colorectal cancer. So it's very safety and easy to our patients. This is the first my opinion. The second opinion, I think addressing the challenge of immunotherapy in MSS type MCRC. The vast majority of MCRC patients has MSS type tumors, which are generally insensitive to checkpoint inhibitor monotherapy. Combination strategy involving immunotherapy and targeted drugs are key direction to overcome the challenges. Consequently, subsequent combination of frequently regorafenib or bevacizumab with PD-1 or PD-L1 inhibitors present an important direction for enhancing immunotherapy efficiency in MSS type MCRC. Several related clinical studies were reported at the year's ASCO and ESMO, but no combination involving frequently were noted. Professor Casey gave us show the new researchers just in the ESMO this year. So it's a potential future direction. This is my opinion. Thank you.
Thank you very much. And as Casey mentioned that we already have some clinical trials on the fruquintinib and also plus the immunotherapy agent. And it's common in China. As I know, there's two major clinical trials is going. It's the chemo plus the immu and plus the VEGF, but both of them are use the bevacizumab. And I hope in the future we can see some clinical trials and use the fruquintinib to see that it also have some effects. I hope so. And do you have any comments on that?
Sorry. I know in the States they had actually conducted, they've done a couple of trials in combination with chemotherapy, but there was some of the trials, they're mostly small phase 2 studies that have been conducted, and also the dosing of the fruquintinib has varied based upon the combinations that have been conducted. From what I recall, there was a full Fury trial in combination, but there were some toxicities in regards to diarrhea. So I think some, I definitely think that fruquintinib has potential in combination. I just think it needs to be fine-tuned in regards to what dose would be most appropriate to start with, and then trying to expand upon that further. I think that there's been some variability between the dosing, which I think it makes it very complicated, because I've seen before it's at 3 milligrams or 4 milligrams or 5 milligrams, right? And I think there needs to be some uniformity, and then you can build upon that.
So thank both of you, personally and Kathy, and we have the first sessions. Now I think we can move to the next sessions, and I would like Professor Lonardi to conduct the sessions.
Yes. So we can discuss both the session at the end if someone has a question. And now I welcome Professor Zhang to speak about the Chinese experience of anti-VEGFR continuum of care in metastatic colorectal cancer. Thank you.
Okay, thank you. Thanks for introduction from Professor Nanodi. And good evening, dear Professor Zhang, Professor Nanoni, and Professor Ying, Professor Xu, and Ji, and everybody. So I'm Dr. Shan Zhen from China, and it's my great pleasure to be presenting here. The topic for today is about the Chinese experience of anti-VEGF continuum of care in MCRC. I'm going to talk about in three parts. So firstly, let's see the importance of anti-VEGF therapy in MCRC. So as everybody knows that angiogenesis is very important in the development of colorectal cancer. Because in normal tissue, blood vessels are organized, while in the tumor tissue, the blood vessels are disorganized, disordered, and also lack of vascular hierarchy. And the anti-VEGF therapy usually can normalize the blood vessel and therefore can improve the tumor microenvironment for that. And because we know that the vascular matrix is composed of endothelial cells, pericytes, and the basement membrane. Initially, the disordered vascular network will have abnormal basement membrane and have a loose endothelial cells and detached pericyte. And all this can lead to an increase in intestinal pressure and also obstruction of substance transport, which is like oxygen and nutrition. And all these drugs, anti-VEGF drugs, can induce the normalization of the vascular matrix and also can promote the recovery of intestinal pressure, and thereby I can restore the transport of oxygen and nutrition for that. And also, I think everybody knows that in our clinical setting, lots of trials and lots of experiments shows that continue using anti-VEGF therapy can provide better benefit, survival benefit, when compared with interrupting anti-VEGF therapy. Actually, there was a meta-analysis of 8 phase 2 and 3 studies. They tried to compare the benefit of continue using anti-VEGF therapy with interrupting anti-VEGF therapy with instead of standard chemotherapy. These two figures show us that continue using anti-VEGF therapy can significantly reduce the risk of disease progression by 36% and reduce the risk of death by 70% when comparing with standard chemotherapy for that. So that means continue using anti-VEGF therapy is much more better. And in our clinical setting, actually we have 2 different kinds of anti-VEGF therapy. The first type is monoclonal antibody, which is like bevacizumab. The second type is a small molecule of VEGF TKI, which is like regorafenib and quinatinib. So both of NCCN guideline and the Chinese statistical guideline all recommend the usage of anti-VEGF therapy in first line, second line, and third line. Let's give a brief summary. So anti-VEGF therapy, especially continue using anti-VEGF therapy, is very important. While interrupting anti-VEGF therapy usually can accelerate the tumor progression. And both of the domestic and the international guideline all recommend anti-VEGF therapy because this can significantly improve the overall survival for MCRC patient. So what does it work? How does it work when we using the anti-VEGF therapy, especially the patient treated with bevacizumab before? Actually, there's a potential mechanism of bevacizumab acquired resistance during continuing usage. The first mechanism is probably there is a compensatory upregulation of other pro-angiogenic factors, which like BFGF and VEGF, CND, and so on. And the second potential mechanism is probably about the bypass activation of alternative pro-angiogenic pathway which is like the Angel2 and TAT2 pathway. And the third is about probably there's some metabolic alteration with increase of glycolysis and also increase of glycylation. And both of them can cause cancer cell to survive very well. So this is a potential mechanism of bevacizumab-acquired resistance. And also, there are two famous studies, which is TML and the BBIP study. So both of the two studies are focused on the continue using bevacizumab beyond progression for that. But both of these two famous studies shows that actually the survival benefit of second-line bevacizumab beyond progression is limited, because we know that from these two studies, we know that both of the PFS and overall survival was improved, very limited. Both of them are improved by less than 2 months. So the survival benefit is very limited for that. And as you know, that the Sunlight study provided evidence for us to using the bevacizumab combined tazobactam as a third-line treatment in MSRC. But if we go details to see the subgroup, the data, especially for the patient who have treated bevacizumab before, the overall survival provided by bevacizumab combined with tazobactam is 9 months, and while tazobactam provide overall survival is 7 point something. So actually, the overall survival was improved is very limited. It's less than 2 months with hazard ratio 0.75. Well, if you go to see the subgroup of the patient who had not received bevacizumab, the overall survival provided by the bevacizumab combined with tazobactam is 15.14 versus tazobactam with 8.05 months. So the overall survival was improved much more great than that of in the group treated with bevacizumab before with hazard ratio 0.40. So all this data suggests that in the third-line setting, continue using anti-VEGF therapy should be carried out by switching to another anti-VEGF drugs for that. And let's review the Japanese rabbit study. Because we realized the Sunlight study, because we use a regular dose with tazobactam, so the combination of bevacizumab combined with tazobactam will bring about a lot of side effects, especially for bone marrow suppression for that. So in the JACA study, they modified the dose of the tazobactam with 1 week on and 1 week off. Even though they decrease the side effects, but the overall survival is not improved. We can see these two curves all come together very clearly with a hazard ratio 0.919. So can we find some way to optimize the anti-VEGF therapy for third-line MSRC, especially for the patient treated with bevacizumab before? So actually, look at these two different kinds of anti-VEGF therapy. There are lots of mechanism of difference between these two, which is like the terms of the main targets, the mechanism of VEGF pathway, the half-life and the size, and the mode of action and the side effects. So, because bevacizumab is monoclonal antibody, it's usually talking actual cellularly, and well, the frequently is a small molecule for TKI and it's working intracellularly and talking on the signal pathway. So probably the risk of resistance carried by the frequently is lower than that of bevacizumab for that. And also frequently is a highly selective anti-VEGF agent, and this may overcome the bevacizumab resistance for that, because frequently can inhibit the phosphorylation of the intracellular kinase domain, and also can stop both angiogenesis and also lymphoangiogenesis for that. And also there's potential mechanism of frequently which may overcome the bevacizumab resistance. Firstly, because frequently has more targets compared with bevacizumab. Secondly, frequently can directly inhibit the more downstream single pathway. And thirdly, frequently can reduce lactic accumulation, and this may overcome the bevacizumab resistance caused by histone lactylation for that. So that's a potential mechanism of frequently we can overcome the bevacizumab-induced resistance for that. And let's go back to see the Fractal study. This is a very famous phase 2 study conducted in China. It is focused on the third-line MSS patient, and it is using frequently compared with placebo in the third-line in MSS patient. And we will go to see the characteristics of ITT population. Actually, in both arms, there are about 30% of the patient got a VEGF inhibitor treated before. And let's see the primary endpoint. So in ITT population, even got 30% of the patient got VEGF treated before. The overall survival is positive. So treated with overall survival, treated with frequently will be increased significantly compared with placebo, with hazard ratio 0.65. And also PFS is positive. So the PFS treated with frequently is significantly increased when compared with placebo, with hazard ratio 0.26 for that. Well, what's the data in the subgroup with bevacizumab treated before? We can see that both of the overall survival and the PFS are improved significantly with a hazard ratio 0.68 for overall survival and 0.24 for PFS. So in such a group treated with bevacizumab before, frequently can effectively improve survival in such subgroup for that. So that means survival benefit of second-line bevacizumab beyond progression is limited. Probably is due to the acquired resistance of bevacizumab. And compared with monoclonal antibodies such as bevacizumab, small molecule VEGF-TKI has more advantages with a shorter half-life and a lower probability of acquired resistance for that. And also, Fractal phase 2 study provides efficacy of frequently in third-line MSS treatment. And also, the subgroup indicates that it can effectively improve survival with prior anti-VEGF therapy treated before. Okay, let's talk to the final topic. So what's the optimization of VEGF-TKI in our clinical setting? So actually, currently, there are lots of clinical trials. They are trying to explore the efficacy of frequently in second line or in third line with combination for that. This is a single-arm phase 2 study. It is working on the third-line treatment for the MSS patient, especially with prior bevacizumab treatment. And it is using frequently combined with tazverimab. The result for PFS is 6.33 months. Overall survival is almost close to 20 months. So all the result is very encouraging for that. And there's another study. It's working on the third-line PMR MSSC, and it is using frequently combined with PD-1. And the result, let's see the efficacy outcome. It is with 6.9 months of PFS and 20 months of overall survival. Still very encouraging. And also there's another real-world study. It is comparing the overall survival, the efficacy of frequently combined with SAI with tazverimab combined with bevacizumab, which is currently golden standard treatment in our third-line treatment. The efficacy outcome shows that the overall survival provided by the frequently combined with SAI is 19.4 months, close to 20 months. While the overall survival provided by the bevacizumab combined tazverimab, this regimen is standard treatment in our clinical setting, which is got just 11.6 months. So overall survival was improved by almost 7 months with a regimen of frequently combined with SI. And also there's exploration to regarding to the efficacy of VEGF TKI in second line. This is a phase 2 study. It's using frequently combined with chemotherapy as a second line. We can see that the PFS is 6.9 months and the overall survival is 20.1 months. It is very effective for that. And also there's another second line clinical trial. It's a single arm, and it is using frequently combined with standard chemotherapy in RAS mutant MSSC. We can see that it got 6.41 months of MPFs, and also the tumor response rate is good. It's with like the 40% for it. So this study also shows that frequently combined with standard chemotherapy is very effective compared with the standard second-line regimen in MSRC mutant patient. So let's give a final conclusion. So anti-VEGF therapy, especially for the continue using anti-VEGF therapy, is very important. And when compared with bevacizumab, small molecule TKI, which is like frequently, has more advantage with a lower probability of acquired resistance for that. And this may overcome the resistance during continued using of bevacizumab for that. And also the Sunlight subgroup study confirms that the efficacy of continued using bevacizumab with prior treated bevacizumab before is limited, while VEGF TKI can effectively improve survival for third-line MSS patients with prior anti-VEGF treated before. And also frequently being combined with tazobactam or immunotherapy can extend the survival of third-line MSS patients. And also when combined with chemotherapy in second-line, it is very effective for that. That's all for today. Thank you.
Thank you. Thank you, Professor Zhang. And it's now my pleasure to ask Professor Simin Su to join for the discussion of those topics and to help us to put in the context of the treatment in the continuum of care and of the late line of colorectal cancer. Thank you.
Thank you, Professor Nolondi. And thank you for Professor San's wonderful presentation. And based on Professor San's presentation, I'd like to share some of my reflections. The first, the benefit of bevacizumab beyond progression in the second line is limited. PFS extended by only 1.8 months, OS extended by 1.4 months, suggesting that Simplide continued the same class of drugs is unlikely to yield significant survival improvement. Resistance mechanisms include bypass signal activation and hypoxia-induced metabolic reprogramming, but the ASCO 2025 conference indicated the switching to fruquintinib after bevacizumab resistance significantly improved PFS, demonstrating that VEGF TKI can maintain the continuing effect of vascular targeted therapy through mechanistic switching. The second, MS or pMMR MCRC, typically immunologically cold tumor, has no response rated to traditional immunotherapy, but fruquintinib plus PD-1 achieve a median overall survival of 20 months in the pMMR population, significantly higher than test 10-2 plus bevacizumab. This result has garnered global attention. Multi-center studies in Europe and the US are using special transcriptomics to assess the promoting effect of VEGF TKI on immunoinfiltration, potentially leading the individualized combination strategies based on immune phenotype. The third, the combination of fruquintinib with HEC or radiotherapy is in the exploratory stage in China, as VEGF-R TKI can improve perfusion in liver metastasis and alleviated hypoxia. They have potential synergistic effect with local therapy. ASCO 2025 Chinese data suggested that the fruquintinib plus HEC regimen can increase conversion rates in populations with higher tumor burden, liver metastasis, potentially becoming an important direction for exploring an integrated systemic local treatment pathway in the future. And this is my options. Thank you, everyone. Thank you, Professor Zheng. Yeah.
Thank you.
Thank you.
So I think that one point of discussion, just to underline the difference between the use in China and in Western country, is the positioning of the drug if in third line or in later line, because you know that as far as I know, you had the approval thanks to the data of the FRESCO trial, where the patients were treated in the third line, while in the Western country, mainly in Europe, we had the approval based on the FRESCO-2 data. That was a trial for patients already receiving trifluridine-tipiracil or regorafenib or both. And so the setting is slightly different. I think that in US, both the possibility are present in the guidelines. But in the meantime, we saw the data of the sunlight, as you showed. And so my question is, now that we have trifluridine-tipiracil plus BEV as an option, do you prefer to go in third line for fruquintinib like before, or do you prefer to go for trifluridine-tipiracil plus BEV and then fruquintinib? Because clearly the landscape is changing. What do you think, Kathy, about that?
So, this is a question that I'm commonly asked about which option would I choose in the third line setting. And I honestly have the discussion with the patient because we have approval for all three agents, right, including regorafenib in the United States. There are clearly patients that have baseline thrombocytopenia because they have heavily pretreated, or they have splenomegaly due to their prior chemotherapy, and they may need a splenic embolization, et cetera. So I don't offer them TAS-102 in that setting. And then, of course, you have patients that are just tired of coming in for their IV infusions. So I do have that discussion. And so it's surprising. It's like 50-50, honestly, in my practice when I give them the option, these are the side effects here, and then they make the decision about whether or not they're willing to come in, or and that really is a deciding factor, just because we're talking third line chemotherapy. So a lot of our patients want a little bit of a mental break, I think, away from their chemotherapy. But I've seen, regardless, I think in the third line setting, I've seen some very nice benefits with both TAS-102, trifluridine-tipiracil plus bevacizumab, as well as with fruquintinib. Fruquintinib just allows some increased convenience.
Yes, and what do you think about this? Or your colleague, or if anybody wants
maybe the fruquintinib is used in MCRC patients and third line. The result is limited. For patients have suffered first line, second line the chemotherapy, and the health is damaged so much. So fruquintinib. So why we can't let the patient use the fruquintinib in second line or in the first line? For some patients, with high blood pressure and or the kidney damaged. The patient need the very strong anti-cancer. So they need a conversion therapy. So maybe they will take the surgery. So the patients will have long disease-free survival or have the longer progression-free survival. This is my opinion.
Yes, I completely agree with Kathy that the great advantage of fruquintinib is that you can meet the patient one per month, and then the treatment is manageable at home. Usually, I have to say that in my experience, is better tolerated than regorafenib, because with regorafenib often you need intercourse visit because the patient are suffering from some adverse event, while I'm not seeing this kind of necessity with fruquintinib. Usually we met them at the beginning of the cycle and then for the subsequent cycle. And as Kathy told, often they are tired to come to the hospital. And so I think it's reasonable to think about this treatment starting from the third line and beyond. For first and second line, I have some concern because for now we know that metastatic colorectal cancer is highly dependent on chemotherapy effect. We need to combine chemotherapy effect and anti-angiogenic effect to see a nice response and progression-free survival in the first line. Fruquintinib being more manageable than regorafenib maybe in the future will be combined with chemotherapy. You also showed some data already. And I think that in the future we might have some more clinical applicability of combination treatment in first and second line. In Europe, for now, we cannot use even in third line because we are approved only on the basis of the FRESCO-2. And so per label, we have to prescribe after the patient received trifluridine-tipiracil, unless it's contraindicated. That might be because if a patient experienced a lot of neutropenia before with the first line and the second line, it's not indicated to propose trifluridine-tipiracil, and so you can go directly to fruquintinib. I think that the most important thing is to have in mind the possibility of a continuum of care that we weren't used to have, because in the last 20 years, we only had fluoropyrimidine, irinotecan, and oxaliplatin, and obviously biologic, but not as a monotherapy, only combined with chemotherapy. So now we are expanding the options, and I think that this is really, really remarkable for our patients. I don't know if there is any question from you?
Yeah, I agree with Professor Ronaldi. Before we have the sunlight trial, the fruquintinib and the TAS, almost the regorafenib, three are equal for the third line chemotherapy. And after the sunlight, we think the combination will be better than a monotherapy. And if we just talking about the fruquintinib single, I don't think it will be better than other, single monotherapy. I think so. If we just look at the efficacy I think the sunlight, the TAS plus the bevacizumab may be the best choice. And up to now, we really don't use the frequently for the conversion therapy because the data now just show the ORR is pretty low, and we cannot expect to have a very high conversion therapy effects. If we put the frequently with other drugs combination, we still don't know the results. Of course, we see some data here. Most of them are some phase 2 single-arm trials, and we still need some randomized trial to prove it's. For a surgeon, of course, we concerned about the surgery after the anti-VEGF treatment. For bevacizumab, usually we have to wait for 6 weeks. But there's some data predict that if we combine with the frequently, the waiting time can be less than 2 weeks or even 3 weeks. If we can prove its efficacy on the conversion therapy, I think maybe it's a way, but we still have to wait for the results before we can use it commonly.
If you wanna say what you think about it.
So I do agree with that. Actually, frequently is used quite often in China in third line, because we know that actually in third line treatment we just have like the small molecule TKI, the regorafenib and the frequently, and the other two is like the bevacizumab combined with TAS 1012. But regarding to the bevacizumab combined TAS 1012, because in the usually patients in the first line or in third line or in second line, half of them we got treated with like the bevacizumab before. So I think the third line we need to shift to another individual therapy for that. So even though we still are waiting for the data, the evidence provided by the regorafenib combined with TAS 1012, right? So in the secondly, if we choose the single agent with like small molecule VEGF TKI, actually regorafenib has very the great the side effects, because we need to modify the dose of the regorafenib. So usually in China, with the average we use the dose like the 80 or 120, right? But in our experience regarding to using frequently as a single agent, usually we can use a full dose of the frequently with 5 milligram. Usually we normally we will not decrease the dose of the of frequently, but actually right now we are in trying to explore the efficacy of the frequently. So if we do lots of trials focus on the combination with frequently, we need to modify the dose for that. So maybe 5 milligram is not okay for that. So that's my concern. That's my concern for that. Okay, thank you.
You wanna add something?
Thank you, Professor Nolodi. We know anti-angiogenic therapy improved tumor microenvironment, leading to the vascular normalization window. During this window, combination therapy can achieve better clinical outcomes. How can we determine the vascular normalization window in clinical practice? Yeah, you have a poster in this ESMO. Yeah, thank you.
Thank you. So I think that if there is no other contribution, we can try to summarize what we said until now. Finally, we have the possibility of a continuous inhibition of VEGF. That is important because VEGF hyperactivation and angiogenesis is a process going along all the natural history of the disease. And so it is correct to start with the first line in the case of bevacizumab, and then we have the possibility to treat along second line, third line, and beyond with multiple different compounds. Fruquintinib is expanding the possibility to control angiogenesis, and now that the drug has been used in the clinical setting worldwide, because China was the first one place, but now then US and now Europe, we understood that it's a manageable treatment. It's convenient for the patient because they don't need to have any infusion. And the characteristic of the drug probably will allow in the future new combination to anticipate the use and to have more option to offer to our patient. One important thing, obviously, is monitoring adverse event. We know that if needed, we can reduce the dose. The important is to try to keep the patient on treatment and not to stop too early, otherwise maybe that we are not able to see the benefit for the patient. And I think that if there are no other thought or contribution or question, I leave to my colleague, Professor Chang, the possibility to close the meeting.
Okay, thank you, Sarah. And it's my pleasure to be here to make last crucial. I think the Fruquintinib already be proved to be effective drugs and safe drugs on treatment with colorectal cancer in the metastatic colorectal cancer. Of course, it should be used in the third line or beyond the third line. It still remain questions. We can still explore that. And doesn't matter it's from China or from the West country. A lot of, even small clinical trials are doing to see the combination of the Fruquintinib with other drugs like the immunotherapy and with some chemotherapy. And I hope in the future, even in the next years, ESMO or ASCO, we can see some results from results from these clinical trials. But I still think that if it's a good drugs and we are going to pay more expectation on these drugs, we still need some large stage 3 clinical trials to prove it. And if we just think of that, and we have to design some clinical trials and show the results to the international colleagues, and then every people can be convinced its efficacy and its safety. But anyway, we gather here and we meet each other and we exchange our opinions and share our experience. I think it's good, and it will prove the treatment of the metastatic colorectal cancer. And at the end of this symposium, and maybe we should take a picture of all of 6 of us, and with them, we move here, stand here, and let's him to take pictures.